When persons are admitted to hospital, they're often admitted to a medicine or surgical team and their needs are met. Their heart failure is treated, their hip fracture is fixed. But at the same time, in parallel with this, there are people coming up with a discharge plan to find ways to keep this person from having to come back to hospital again. They'll get proper referrals to groups like our LHIN for PSW supports. They'll be connected to social work as a community if necessary. They'll be connected to Catholic Family Services if necessary. But sometimes someone needs to sort of lead the charge to help coordinate these services in a logical, rational way to help to corral all those elements together that have been identified from the initial validated assessments and tools that have been done throughout their hospital stay.
I was so sick, you know, and I was like, I don't know, I was ready to give up, you know, because my family, I didn't see my family for a long time. I was in a shelter in Oakville, and then I ended up in hotels, and then a shelter in Hamilton, and there's not a place you want to be. You know, like I've never been anywhere like that before in my life. But once I was in the shelters, there were no doctors. There were a nurse there, like in the shelters, but they're not really, you know, they're not equipped to deal with anything like that.
I think the very first step is asking the person you're seeing, asking the patient, well, what do you want? What do you need? What's most important to you? What's keeping you from being satisfied and limiting your ability to stay out of the emergency department, out of health trouble? And that person say maybe something like, I need a refrigerator. You know, if they don't have a fridge, they can't store things that need to be kept cool. They can't store groceries they bring home. And something as simple as getting a donation, like this team will solicit donations amongst themselves, with the hospital, intranet, with other places in order to help connect that person to something they don't have already.
They helped me with everything. Living, got me this place, you know. They helped me with the shopping, the food situation. They would bring me them all the time because they were too heavy for me to even carry from the pharmacy.
And once you build these bridges and this trust, they'll allow you to do things like, okay, let's look at changing your medication. Let's get you to this outpatient appointment. Let's get you to this adult day program. Let's get you to something different than what you're doing now. Because if you always do what you always did, you're always gonna get what you always got. And this team is to sort of shake up the box, shake up the problem, look at it from a different angle, because if you don't personalize what they need and individualize what they need, then that person's just gonna brush you off. And then they'll show up back again the next day in the emergency department with a similar or the exact same problem again. Yeah, after identifying these frail persons from the ED using the AUA screener, they're referred to the Centralized Care and Transition Team. This is an interdisciplinary team of healthcare providers with experience in assessing and caring older persons, and they use standardized, validated tools and instruments to put together, through a geriatric-friendly lens, capturing information about their mood, their memory, their function, their social supports, medications, everything that's important to keep that person healthy, alive, and satisfied.
I know I've got people to talk to now, or call, or, you know, come and see me like before in some of the places I've lived. No, I feel, I just feel they've just done so much just to get my life back on track.